Well, thank you so much for inviting me today. It's a pleasure to talk to you all. These are my conflicts of interest, which are also listed, and I also serve on the ABIM, but don't throw the tomatoes that John Marshall mentioned. So just go over a brief introduction. Actually, this talk works out kind of nicely. I'm building on a lot of themes that some of the previous speakers brought up, and I'll go through 5 sort of up-and-coming targets, 2 of which have some initial disappointing results, I'd say, but we'll sort of go through that. So this is actually a logarithmic plot of somatic mutations versus different cancer types, and you can see that GI cancers, perhaps because of all the environmental exposure and all the stuff we're eating, tend to have more mutations than many of the other the cancer types. And if you look at something like the Cancer Genome Atlas, you can see that most colorectal tumors, for instance, have a lot of chromosomal aberrations, but they definitely split off into this hypermutated group and a non-hypermutated group. So hypermutated group being, think of those as, because your MSIH patients sit in this group as well. And then you start to get a hint of how these things can sort of co-express in a way. For instance, BrafN, there's a lot of overlap with your hypermutated group, and I'll touch on that in a moment. And luckily, through all these Cancer Genome Atlas studies, on the one hand, it's been a little depressing because we've seen so much heterogeneity in tumors. On the other hand, there really haven't been a lot of new pathways discovered. I know the Hippo pathway was mentioned earlier today, but in general, not a lot of new pathways, and so that's some encouragement that hopefully we can be pathway-based. The other thing, again, is, for instance, TGF-beta. If you look at non-hypermutated versus hypermutated, 87 versus 27%. So as we start to think about these various groups, we're going to see different aberrations. This is a slide from Heinz Lenz, just showing different molecular clustering of colorectal cancer, and from various groups, various large trials. And you can see most of them, for instance, have this sort of MSIH dark blue group. But there's a fair bit of heterogeneity with how this all falls out, and there's a lot of efforts towards combining these data sets and trying to drill down a little bit more. The Genome Atlas for gastric cancer was mentioned earlier as well. I just point out, it's a little bit like colorectal cancer in some ways, in that as you go from right side of colon to left side of the colon, you see these different patterns, and the same thing here, where the chromosomal instability predominates in the cardia, MSI much higher in the antrum, as covered by the other speaker. So let's start going through some of these pathways, and we'll start with sort of the big gorilla, which is RASS. So, RASS is such an interesting topic because it's one of the most commonly mutated tumors. Look across colorectal, lung, pancreas, very, very common. You're talking huge numbers of patients, 137,000 patients here. And then look at some of the different patterns. For instance, why is it that colorectal has codon 13 mutations, whereas that's extremely rare in pancreas cancer? So all these are questions that really need to be resolved, and there's a whole group at the NCI working specifically on RASS, because if we can solve this, we can really make some progress. So what are the challenges? One thing you'll notice about RASS is that if you notice, almost all of these start with a G. Glycine. So what is it about glycine that's different, if anyone remembers from their pre-med classes, right? So glycine doesn't have a side group. So the problem with codon 12 and 13, they sit in this P loop, and this is where you need to take GTP down to GDP. You pop any other amino acid in there, and it's going to cause steric hindrance. And so this is one of the problems with this. And 12 and 13 is where a lot of the action is. But you also have these different switches, which also mediate binding, and so those are probably why those seem to be the implicated mutations. The problem with targeting RAS, of course, we think of things in a linear pathway, and I'll show you there's more than 20 pathways downstream of RAS. And the other issue, we've got these feedback loops, and mutant KRAS doesn't necessarily correlate with ERK activation. BRAF, as hinted by other speakers, and I'll build on that a little more, has different roles, and thus far, at least monotherapy inhibition below BRAF or MEK really hasn't yielded the type of results that we need to see. And now we've got a much bigger problem, because as Axel pointed out, if you start adding up, now they're small numbers, but 2 to 4% plus 2 to 4% plus 2 to, it starts really adding up. In some data sets, as many as 20% that you have these newer RAS mutations. So we really don't talk about KRAS anymore. We just talk about RAS. And as Axel said, as I do a lot of second opinions, I don't know if you have the same thing, Axel, but I still see a lot of patients who only have KRAS codon 12 and 13 testing, and I really think it's important to get deeper in there because this light blue, so we've always known about KRAS canonical mutations, if you will, 12 and 13, about 40%. Now we're pushing out to 59, 61, 146 on KRAS, and then we got NRAS, and it all starts to add up to where this blue line is going to be over here. And unfortunately, we really don't have an effective therapy for upwards of 60% of these patients. And if you look downstream of KRAS, it's not a linear thing where it's just one kinase, one pathway. You can see about 20 different pathways feeding in here. It's going to be very difficult if we take the technique, and I'll show you some of the ways we're thinking about blocking RAS, but if you take it as sort of trying to block downstream of some of these signaling, you're going to have to hit a lot of targets to block the full signaling pathway. So here's some of the strategies that have been used. One is inhibitors of plasma membrane association. Of course, tipifarnib was one of the first ones that tried to do this. Turned out not to hit both pathways because KRAS really needs to sit on this inner leaflet. But unfortunately, those alternative pathways, I think people are still working on this. A lot of work into inhibiting downstream effectors. The problem with direct inhibitors, and again, there's been a lot of work on this. We're hoping to crack this nut, but the problem is that humans have not designed a picomolar drug yet. So RAS, there's picomolar affinity. We've hit micromolar and nanomolar. We've never hit picomolar affinity for the GTP, GDP. So that's one of the main challenges with developing these direct inhibitors of RAS. These are some of the ongoing trials. Almost all of these are looking at either combinations with conventional therapy or combining two downstream inhibitors. I'm familiar with some of the data, early data from a lot of these trials, and so far we're definitely not hitting home runs. This is an example of a study that came out at Colorado, where basically we looked at MEK inhibition. This is from the Eckhart lab, and we're looking at what are called synthetic lethality screens. So you use viruses to sort of screen for thousands and thousands of genes to see what other genes are important, and lo and behold, the Wnt pathway popped up. And then we took it in vivo. This is a patient-derived explant, and you can see very nice synergy between these. And furthermore, if you started with one agent and then added the other, so if you started with MEK and then added Wnt, or started with Wnt and then added MEK, you got this nice decrease. So that's an ongoing study that's actually in the ECT and UM1 mechanism, which are 10 centers. So what about BRAF? So the most common mutation here is V600E. It actually used to be called 599E. And so I'm not that old, but actually I used to, when I was doing some of my early lab work, sequencing we were doing by hand and actually counting with the gels. You can tell how fast the field has moved. It used to be called 599. I think someone just miscounted. But it signals through ERK and MEK. It's an early event, and it's associated with several of these sort of clinical factors. Obviously, you're going to want to test your patient, especially if you're going to put them on a study. But there are some clinical factors: right-sided, older age, female, MSI high, and I'll talk about that in a second, and SARE rated. So this MSI status is pretty important to think about. When you're looking at a data set with BRAF, you want to, hopefully they're going to include this, but basically when you have a BRAF mutation, you often get epigenetic silencing of some of the DNA repair proteins, and so that gives you that good prognosis from MSI high, so it sort of blunts the effect of a BRAF mutation. Of course, obviously you'd rather be MSI high, wild-type BRAF. But if your microsatellite's stable, BRAF mutated, that's bad news. And this has been reported actually for quite a while. This is a 2013. A lot of this comes from the Harvard group, the Nurses' Health Study and Physicians' Health Study, where if you're in the red, so if your microsatellite's stable, so you don't get that good bump from your MSI, and you're BRAF mutated, you're much worse off than if you're MSI high. So you can see the difference there. In fact, you're almost doing better than that middle group, the MSI high group there. So it actually is important to consider these two biomarkers together. Here's where the mutation occurs. It's in the activation segment, and it really has a major impact, 500-fold greater kinase activity when you have this mutation. So I guess it's not too surprising. This seems to be the mutation that we're often seeing in patients. Mutations in other, it depends what type of assay your group is using. If you're using a PCR-specific assay, you're only going to pick up V600E. If you start looking at other mutations, you're going to pick up other ones. But oftentimes, the significance of those is not as well understood. As Axel mentioned, BRAF and RAS do not intersect. So if you have a RAS mutated tumor, either KRAS or NRAS, that does not overlap with BRAF. So if you have a RAS mutated patient who's coming to see you, you really don't need to test for BRAF. It is a negative prognostic factor, and I always find this sort of tricky to talk to patients about because at this point in time it doesn't affect treatment in terms of the package insert. As Axel mentioned, there's some techniques and some trials that are coming about. But you do need to talk, I think, with your patients about some of the prognostic implications in terms of life planning and things like that. As Axel showed this, showing just that one patient, this is actually one of the most off-quoted abstracts because it hasn't been published yet. Just that one patient had a response, but this was actually somewhat predicted preclinically. Monotherapy inhibition really didn't have a great effect in colorectal cancer cell lines. But help is on the way. So Axel mentioned first line, the FOLFOXIRI Bev. That, of course, has a limited number of patients. It's only 28 patients, so we have to be careful there. But if you look at some of these combination studies, BRAF-MEK, BRAF-MEK, EGFR, BRAF, EGFR, irinotecan, you're starting to get much higher response rates here. We'll see if this translates. And as Axel mentioned, this is now a SWOG intergroup trial. And hopefully, if you have any interaction with SWOG or some of the other cooperative groups, you can open that trial, because certainly we need to work together to find these smaller patient subsets. So what about FGFR? So FGFR is regulating a number of different oncogenic pathways. It's very complicated, 18 ligands and 4 different receptors, signaling through some of the usual suspects in terms of downstream pathways. And it's implicated in, it's dysregulated in a number of GI cancers. So theoretically, this should be a good target to go after. If you look at how these things are aberrant, you'll see mutations, translocations, alternative splicing, amplifications, et cetera. So there should be a number of biomarker groups to go after. And you can really put these, this is actually true of many of the targets. If you look at, you've got your general non-selective TKIs, your selective TKIs, or we think they're selective, and then your protein-based, these tend to be monoclonal antibodies or traps to hit the ligands. And so you can tell there's a lot of work being done to look at these. The problem is that in GI cancer so far, we've sort of been whiffing. So brivinib in colorectal cancer really didn't add a lot to FOLFIRI. In combination with cetuximab, Lily and Sue presented at last year's ASCO, showing that it improved PFS and response rate, but no improvement in overall survival. Same with HCC, both first and second line, the BRISC trials. Both of those trials were negative in HCC. These FGFR amplified ones, so this is a fairly small subset of patients. So the jury, we don't have very mature data on this one. And so stay tuned on whether or not FGFR amplified or FGFR IHC will be a marker for these. So there's some early signals of anti-tumor response, especially in FGFR amplified cancers. Main side effects are similar to other VEGF targeting agents, but one thing I tell you is what's scary with us in our phase 1 program, we did a number of these, is you can get some very severe hyperphosphatemia to the point where you're starting to worry about precipitation of calcium and phosphate in the bloodstream. And so these patients have to be managed very carefully with the low-FOS diet and binders. And as these things if they get approved, it'll be interesting to see how that gets managed. And it is challenging to find these FGFR amplified patients. Stay tuned on whether IHC or amplification will sort of help save this target group. So what about c-Met? So as John mentioned, we've got c-Met is an important target, or seems to be. We've got ligand targeting antibodies, receptor targeting antibodies. It's interesting that John mentioned tuvatinib. Actually, tuvatinib may not be a c-Met inhibitor, or at least that might not be the mechanism of action for that drug. It's actually been shown to be independent of c-Met binding. So the jury's still out on exactly how that drug works. This is just sort of an anecdote of why you have to be careful, in my view, of sort of adopting data from a smaller trial into your practice. So look at this data. So you have conventional chemotherapy. This is gastric cancer, looking at 2 different doses of your drug versus placebo. And this was presented in abstract form. The blue line is the arm that's getting the AMG 102. And you can see some improvement, mild improvement in progression-free survival and overall survival. But if you look at CMET high patients, you get a really nice hazard ratio, 0.29. And you get a much better separation of the curves for the CMET high group. How many hazard ratios of 0.29 did you see today? Not that many in the GI cancers. I think CML had 0.17, but other than that, that's close to a record. And then, as John mentioned, it was predicted to be CMET high, but it's poorly prognostic. And this is really important to tease out when we're working with biomarkers, what's predictive and what's prognostic. Because if you don't do a biomarker negative group, or you don't have a control group with placebo, you could be thinking you have a predictive effect when in fact you have a prognostic effect. Prognosis being independent of what treatment you're getting, predictive meaning tied to a treatment. However, so this looks like a great story, right? Hazard ratio 0.29. Should we just treat our patients? Why are we going to bother waiting for a phase 3 trial? Well, this is why you wait for a phase 3 trial. 2 phase 3 trials in gastric GEA cancer were halted due to a higher death rate. Okay, so if you had adopted that early based on a randomized phase 2 trial, you would have basically been killing patients for God knows what the cost would be. So to me, it's sort of a cautionary tale of we have to look out when we do randomized phase 2 trials as we go to phase 3 what the effect's going to be. METMAB has not been much better. This is one of these one-armed monoclonal antibody trials. This was studied in colorectal cancer. Looking at FOLFOX-Bev placebo, FOLFOX-Bev onartuzumab. There's also an ongoing gastric trial in this, with this agent as well. And unfortunately, in the colon trial, there's just really nothing that was seen here in terms of an effect. In fact, there was a little bit of a trend towards the CMET low group getting benefit, which didn't really make sense. So I don't think this has a bright future in colorectal trial. We'll see what the MET gastric study shows. So what about another CMET inhibitor, XL184, Cabozantinib? So this is FDA approved for thyroid cancer. It inhibits several other targets in addition to MET and had a progression-free survival benefit, fairly impressive in thyroid. Well, it looked actually pretty interesting in HCC, and there's a larger HCC trial that's going to be done with this. Cabozantinib that they did have, it's a fairly small company. They had a negative study in prostate, and so they've had some funding issues, but I think some interesting results. And again, the Arcule drug may not be a MET inhibitor, so I think it's important to hopefully follow this story through. What about immune checkpoint inhibitors? Well, just to remember, if you see lymphocytic infiltration on your path report, and it's captured in many synoptic path reports, you got to start thinking about MSI high patients. And that's been known for a long time to be a positive prognostic factor. In fact, it may be all of those neoantigens. So when you have MSI high patients, you have 1,200 mutations, not 70 mutations. And maybe those neoantigens are what are leading to the better prognosis. So unfortunately, so far with CTLA-4 and PD-1, we just have not seen much in GI. It's sort of frustrating. GI cancers always tend to be at the bottom. There may be a biomarker. This should be a question mark, really. And there's a lot of work being done. You can't really stain for PD-1, so most people are staining for PD-L1, looking at stromal factors or on tumors to try to figure out if that's a biomarker. So we'll just have to see how this plays out. As mentioned earlier, the Keynote Trial, so this is Pembro and gastric. This is presented at the GI Symposium. So about 40, they tested patients. They had to have at least 1% in either stroma or tumor. So 40% came out with some staining. And this was both first line, but mainly second or third line. And fairly impressive, this is a single agent trial, fairly impressive, 33 by investigators, 22% by central review response rate. And what was more important, and I think to me is sort of the most promising part of immunotherapy, is that these were often durable. So the green triangles are the responses, and you can see where you have a green triangle and there's nothing at the end here, that means the patient is still on study. So there's a lot of durable responses, and the 6 out of 8 were sort of still ongoing, which to me would be the best value proposition, as John mentioned, With a lot of our targeted therapies, they're expensive and you rapidly get resistance. If these things can last for a while, that would be really promising. This is, in the title of the thing, it's talked about how it's going to tie PD-L1 expression. And here's some examples of stromal and tumor staining or tumor staining. And it narrowly missed its p-value, but there really wasn't a lot of detail given as to what sort of pattern they saw in terms of response rate and PFS. So hopefully, as time goes on, this will develop. But I know there's 5 different antibodies looking at PD-L1, so this is a rapidly evolving field. The follow-on trial is going to be Keynote 059, so it's looking at Pembro in 3rd line, or Pembro chemo, or Pembro alone in untreated patients. So that's sort of the follow-on trial. It'll be interesting to see what happens with that study. In colorectal, I'd say so far not exactly hitting home runs. So this is the Genentech compound 3280, PD-L1 targeting, looking in combination with Bev or FOLFOX-Bev, and there's these CRC groups in both of these. I think you can argue that in the Bev PD-L1 arm, certainly some impressive stabilization of disease. We have this trial open at our center, and we have some very prolonged stable disease, but really not too impressive in terms of response rate. I would say not sort of impressive enough where you would design a trial based on response rate. And as Axel mentioned, when you have a progression-free survival in the first-line setting of 10 months and you can't design your trials on response at all, it gets a little tricky. You start to have to do really big trials to show differences. One good thing that should come out of this PD-L1 trial, though, they're doing a lot of pharmacodynamic analysis. Here, just showing that CD8 cells, after pre-treatment to cycle 4, you're getting an infiltration of lymphocytes and expression of inflammatory markers. So I think that will be a useful study to sort of look at some of these biomarkers and some of the pharmacodynamic effects of PD-L1 expression. And then just building on the story that Andrew was telling about the GVAX vaccine, and it's nice to see this going along. I spent 7 years at Hopkins. I put a ton of people on GVAX monotherapy. Didn't work all that well, but when it's being combined with some of these other agents, seems to have some efficacy. And we actually have that Odura trial open at our center. So hopefully we'll make some progress in pancreas cancer. Finally, just to wrap up with TAS-102, so the RECOURSE trial. So what is TAS-102? So it's trifluridine. It's a nucleoside analog. It's activated by thymidine kinase, so it's a little different from 5-FU. And thymidine kinase, TK1, thymidine kinase 1, may be a predictive marker for this. And then tipiracil hydrochloride, this is a phosphorylase inhibitor. What's interesting about this, so the whole idea here is to inhibit metabolism of this drug, okay? But it turns out that thymidine phosphorylase has some homology with PDGF. And so this drug, this co-drug also has angiogenic properties, and that might be why it's better than just 5-FU alone. So the RECOURSE trial was a global phase 3 trial and randomized 2-to-1 to TAS-102 or placebo. It was building on this, which was published in Lancet Oncology in 2012, and very similar hazard ratios we're seeing in phase 3. So hazard ratio of 0.56, not a great median survival difference. But the RECOURSE trial showed sort of a similar type of thing in terms of a hazard ratio of 0.48. And as Axel mentioned, you start to wonder about a subgroup when you kind of get this later separation. And I know they're going to be looking at thymidine kinase 1 levels. It'll be interesting to see what that shows us. And this is the overall survival difference with that trial. So in conclusion, I think we have a vigorous pipeline in GI cancers, but progress has really been incremental. Tumor heterogeneity, a bunch of the other speakers touched on that. It's a major problem. Immune checkpoint inhibitors, we just have not been hitting home runs. And frankly, right now the companies are really going for those home runs. They're not too interested in GI right now. Hopefully we'll come back to that and figure this out. Most novel agents, has a biomarker hypothesis, but every agent that's been approved recently, zivaflibercept, regorafenib, et cetera, they have not had biomarkers. So no pharmacodiagnostic test. And then, as many of the speakers have touched on, we really have some challenges here with our clinical trials infrastructure, because right now we don't have an infrastructure where you're everyone is sending their samples in and then getting parsed into different trials. And Dr. Marshall mentioned some of the challenges and just the sheer numbers that we're going to need to get this job done. Thanks so much.